Thank you very much. Pleasant duty to talk on an important trial that was released this year, and that is called the Verify trial. And I'm going to speak about the perspective of this trial from an Indian setting. Now, the whole point of the trial was that for a large number of years, we know that when we target therapy in diabetes, we need to do so in an early fashion to start treatment right from the beginning in an intensified fashion and use multiple drugs probably to target the different pathological mechanisms that result in type 2 diabetes. So combination therapies, which are the real I would say a gift coming from India, are now accepted world over, and people have started recommending combination therapies for diabetes. The question is whether the thought was never challenged scientifically. We didn't really know whether doing this as a combination really helped the patient, and therefore is it really necessary and beneficial to do it. The glycemic targets in type 2 diabetes have been settled for long, and by and large we have settled on a HbA1c level of 7, and that is more coming from retinopathy data, which, as you know, that there is an inflection in the inflection in the percentage of retinopathy after a A1C of 7%. So 7 has been generally the target to achieve. We also know that if we achieve this target early in diabetes and keep it for a long period of time, there is a legacy effect, which means that if the control is less than 7 in the first 2 to 3 years of therapy, the benefit is long-term and persists even 10 years after the stopping of the UK PDS trial, as you know. So at the end of the trial, there was no significant difference in the macrovascular outcomes, but when the cohorts were followed up for another 10 years, those who were controlled tightly, that means less than 7 for the first 3 or 4 years of therapy, always did better even 10 years after the closure of the trial. That is called the legacy effect. The same thing was seen in other trials as well, that the HbA1c level of more than 6.5 for the first year after diagnosis demonstrated actually worst outcomes. Again, we know that if you have good control in the first year, the microvascular complications go down by another 40%, and even macrovascular complications, including death, go down by another 29% or so. So it obviously means that there is a place of intensive therapy coming right at the beginning of therapy, and this was known, but this was never tested in a randomized controlled fashion. And the whole purpose of the Verify trial was to put this question to test, or this hypothesis to test, that is, whether those with type 2 diabetes benefit from having combined therapy right at the onset of their pharmacological treatment. This is in contrast to the view that we could start with diet and exercise, wait for some time, and then start metformin, and then wait for some more time, and then add one more agent, and then add one more agent, and so on, which we call sequential intensification. Rather than that, is it beneficial to just start with a combination right from the beginning to see whether they last longer in control? And the secondary question that was being asked is that if we do that, and if these patients do benefit, do they benefit more than the sequential question? And the final question is, all this, does it really matter for the patient? So this was the question being put to test in the Verify trial. It's a global study, except North America, where vildagliptin is not recognized by FDA. It had a presence in practically all other parts of the world, including Asia, and we know that particularly in Asia, there were a large proportion of patients coming from India as well. The trial design was pretty simple. People were allowed to just start metformin. The dose was titrated to reach a maximum of 2000 or the maximum possible tolerated, and then after this got settled, they were randomized to receive either just metformin and a placebo, or they received metformin plus vildagliptin. So this was the whole purpose of the trial. And then these were followed up. There were visits every 3 months to do the HbA1c, and the HbA1c target was less than 7. If these patients failed at 3 months to show HbA1c of less than 7, from metformin, they were moved on to metformin plus vildagliptin. And if that also failed, we added insulin. In the other group, which received metformin and vildagliptin to start with, if they did not fail, they continued for 5 years. If they failed, they were put on to insulin. So this is how the trial was designed. So 3 drugs in total, metformin alone, metformin plus vildagliptin right from the beginning, and if this fails, insulin. Now this VERIFY is interesting from another perspective. If you look at many other trials which are related to diabetes, a lot of them, like these for example, the VADT, the LEADER, the DECLARE, CANVAS, CARMELINA, SAVOTIMI, ADVANCE, TCOS, all of them are in people with diabetes for 10, 15 years, A1C quite high, patients on multiple drugs, multiple comorbidities. These are basically advanced cases of diabetes with multiple complications and comorbidities, and then they were tested. As compared to that, you have UKPDS, which is similar to VERIFY. UKPDS also started off in newly diagnosed patients, and so is VERIFY. I'll show you the trial design, who were the patients included, but basically it is at the start of diabetes when not too many comorbidities and complications are already present, and the patients are relatively drug naive. So this is an important place of this particular trial in the overall scene of diabetes trials. If you look at the criteria, the age average was 18 to 70 years, the BMI was 22 to 40, so representing a wide range. HbA1c, can you see this? It was between 6.5 and 7.5. In all other trials on diabetes, the average HbA1cs have been close to 9. The eGFR was more than 60, so there was no CKD. The diagnosis of diabetes had been done for less than 24 months, and these patients were drug naive, except maximum of 4 weeks of metformin was allowed. So basically, these were relatively uncomplicated, newly diagnosed patients with diabetes. And this is the proportion coming out of India, the largest numbers coming from India. And if you look at the way in which the India patient disposition occurred, total number of 318 screened, some of them underwent, they failed in the screening test. Finally, we could randomize 163, 82 to the metformin vildagliptin group, 81 to only metformin group, of which a large majority completed a trial of almost 5 years. If you look at the characteristics, this is very different from other characteristics. 62% men, that's fine. But what I want to show you is the duration of type 2 diabetes is a max. The average was about 5.3 months. So they are relatively newly diagnosed diabetic patients. The age is also not very high. In many trials, the age is much more. Here, the average age was 48. The average A1C was 6.8. You know, in our practice, we would not even be thinking probably of starting medications for an HbA1c of 6.4. But here they were started on the max dose of vildagliptin plus metformin. The BMI is 27, very typical for India, not very heavy. And the baseline eGFR was 75, which is nowhere close to CKD. So these are important things. And what were the results that came out of the VERIFY? The first question, the primary outcome of the study was to address, do those with type 2 diabetes benefit from having combined therapy at the beginning of their pharmacological treatment rather than a single therapy? And what do we see here? That as compared to monotherapy, when you use the combined therapy from the beginning, the hazard ratio of failing on treatment, that means HbA1c going beyond 7%, you can see here that there is a clear 53% reduction in this particular primary outcome, a very, very significant statistically outcome for this particular population. What does it mean? That if you start a combination right from the beginning, the chances that these patients will fail is down by 53%, and this is what you get. The incidence of initial failure, 59% for monotherapy, 43% for the early combination. What was the global statistic for the same trial? This is the India's sub data. This is the global data, 62% versus 43%. So clear reduction in the primary failure rate. And what is also something which, I learned and I found it very interesting was that those who used metformin alone, the median time for failure, that means 50% of patients failing on therapy. What was the time duration? It was 1.5 years. And what was the failure time for combination therapy? It was almost 4.7 years. So you gained an additional 3.2 years by just being on a combination right from the beginning. So the durability of therapy significantly changed between group A and group B. What are the figures from international? The initial monotherapy failed at around 3. The combination therapy failed at around 5. Look at the data of India. At 1.5 years, metformin failed. And this is now keeping with the fact that Indians not only have insulin resistance, but they have significant insulin deficiency as well. So only metformin is not likely to work very long. So we are talking of a median data. It means 50% of patients. I'm not talking of each and every patient. So 1.5 years they failed. Globally, they failed at about 3 years. This is something which is important to note. What about time to fail on the next step? That means if they had failed on metformin alone, I said that they had been converted to metformin and the vildagliptin combination. And then when did they fail next is the question. And if you look at that secondary outcome, you'll see here that the data shows that as compared to the initial vilda-met combination versus the initial metformin combination, the chances of failing second time is reduced. The hazard ratio is 0.42. So a clear resounding 58% reduction. This is the incidence of second failure. 37% in the monotherapy group versus early combination 19.8. So what does this mean really? It means that not only do they fail less number of times to begin with, but after metformin is failed and after you add vildagliptin, what is called the sequential intensification, that also does not work as well as starting a combination right from the beginning. So the second question is that they do more better was also answered by this particular data. And if you look throughout the trial, a greater proportion of patients in the early combination group versus the monotherapy consistently had an HbA1c value of 7%, and this is data across 5 years taken at every 3-week intervals. So this is something which is very assuring to find. So the key findings that actually came out of the VERIFY study was that if you start an early combination treatment, it halved or it reduced by 50% the risk of time to initial treatment failure. That means just using metformin alone would tend to fail much earlier and much more frequently than a combination of metformin plus vildagliptin. And the median time to initial failure with monotherapy group was 1.5 years, whereas in the combined group it was almost 5 years. So it's almost triple, and that is something which is very important from our perspective. It gives us much more durable control, especially in a country where follow-ups are not so realistically regular. When all patients were receiving combination therapy, that is in the phase 2 of the trial, the risk of time for second treatment failure again reduced by 58%. So what it means is that those who were already on the combination continued to have better control than the patients who were sequentially accelerated on therapy. So the strategy of an early combination treatment approach with vildagliptin plus metformin in patients with newly diagnosed type 2 diabetes significantly and consistently improves long-term glycemic durability compared with metformin monotherapy. If you look at the commentary on recommendations coming from the different societies, Stefano Del Prato put it very nicely. So the initial recommendation was if you see all guidelines, they'll say lifestyle, then metformin, then if this not controlled, add this, etc., etc. And if you read the bottom lines, it says early combination therapy still not recommended for lack of inadequate evidence. And now it says it can certainly be tried because there is some evidence, at least with one group of agents, saying that early combination therapy actually works better than just a monotherapy with sequential intensification. Thank you very much for this opportunity to speak to you.
Thank you, Doctor.